Okay, good. So, sex development, pathology. So we are continuing our lecture from previous time. And I also added Turner and congenital adrenal hyperplasia. So these two diseases, they are the ones that you should know very well for this question. Congenital adrenal hyperplasia is very big topic, so we only discuss the most important subtypes. Turner and Klinefelter as well, but Klinefelter is more common, but they ask Turner in the exam, so know your Turner very well. And then we have some other diseases which we can use to explain sex development disorders, which just know the basics for them. If they ask you, like, just know some basics for it. So I'm gonna go through these ones that you need to understand. And then I'll just talk about Turner and congenital adrenal hyperplasia, because you can find a lot of information on these diseases, the very important ones, but no one really discusses, or it takes time to find information for this. So I put it in the presentation for you. Okay, so DSD, disorders of sex development, how are they classified? What is it based on, the classification? It's based on what?
You mean like virilization or hirsutism or something?
Yeah, so that's one way to do it. It's to say I have hyper-virilized female and hypo-virilized male, let's say. So that's a very nice classification based on pathophysiology. But the official classification, to be standardized and easier for doctors to talk, it's based on karyotype, okay? So yes, like hyper-virilized females, but we prefer to say 46XX disorders, and hypovirilized males like 46XY disorders. And the last one is sex chromosome. So they make their own category for sex chromosome. And then the classification looks like this. We have the sex chromosomal disorders. So that's your Turner when you're missing an X, and your Klinefelter when you have an extra X. But remember that these diseases, they also have variants, okay? So that's why they are classified as one disease, let's say, Klinefelter and variants, because Klinefelter syndrome is not just one disease. Same with Turner. And also, like, we have in this category mixed gonadal dysgenesis. We talked about it, I think, last time when defining it, chimerism as well. And then we go here to XY, that's your problems of males, so hypovirilized males. You can classify them based on like testicular development or some androgen, if they have like a synthesis problem or effects problem. And then when we jump to females, we have ovary problem, so not testicles, ovary problems. And then if they were exposed in some androgen during fetal development. So here is your congenital adrenal hyperplasia as well. Yeah, and some other as well. So this is the official, let's say, classification. Uh, it's good to think like we have like hypovirilized males and hypervirilized females, but then we cannot add the sex chromosome disorders like Klinefelter and Turner. So we have this classification based on karyotype. Okay, so newborn, we have a newborn now, and it's diagnosed with disorders of sex development. So they are considered like endocrinological emergencies. Okay, what is important to do in the newborn is make an accurate gender assignment and diagnosis, so and manage all the future risks. The problem here is it's a new baby. Okay, we have the parents now. It's not just the baby, it's not just our patient, we have also the parents and family inside. So congratulate parents for the baby, like take care of the parents, tell the parents we don't know the gender yet, advise them to keep it secret for now so you don't stigmatize the child. And then we have multidisciplinary team, so endocrinologist, urologist, that will be your surgeon for the genitals, geneticist and psychologist. So everyone is affected, not just the baby. Yeah, and we assign the gender only when we're sure. You don't have to do the karyotype. Sometimes you don't have to do it. And you should take parental consent when taking photos. Okay? Any questions for this?
No.
Okay. So moving on. Take your history. Okay, so that's your prenatal and perinatal because it's a newborn, right? So see what the mom was doing, if she had any medications, if she had some symptoms or signs of excess androgens during pregnancy. So this can be a hint as well. Family history, we're looking for like genetics, right? So everything that can affect, we said puberty is very closely associated with sex development. So any puberty disorders, how it was, anything other genetics, hereditary diseases, some other clues that can show us that the cause would be, and also history of stillbirth and sudden death, because some genetic diseases they will die like in utero, right? So we cannot make the diagnosis. We don't know why they died, but we know that they died. So stillbirth, sudden death, it's just a big category of yes, there was some problem, but we don't know what. So maybe we can find in our new patient, in our newborn, and then we can guess maybe that's why the older child, the stillbirth or sudden death, died by the similar cause maybe. So this is also a clue, okay, that something could be going on in genetics. Physical exam, head to toe, okay? So we have to check everything. But first thing you do is the emergency ones, okay? So the most emergency here is to be aware of congenital adrenal hyperplasia, the classic type, the salt wasting subtype, okay? So just check if there is dehydration, failure to thrive. These are the most important signs for congenital adrenal hyperplasia, salt wasting classic subvariant. So check these first, and then we continue on with the head to toe. Because in emergencies, you don't go like ABC. You, I'm sorry, like I mean, you have very common cause for this is congenital adrenal hyperplasia. So exclude that one first. Then you do your ABCs and then you go to head to toe. Okay. So start focus first because it's an emergency. In males, you have to check the gonads, so that's your testicles, if they dissented or not, if it's symmetrical or asymmetrical. We discussed this in the previous lecture. Any hypospadias, epispadias, phallus length, just check the genitals, so internal, external. Check if there is some cord that could be a sign that there is associated congenital malformations as well. Just remember that in preterms, okay, and in newborns, prepuce covers the entire glands and it's not retractable. Okay, this is normal because in adults it's called phimosis, but in newborn this is normal. Okay, when you're checking the glands and the prepuce of the newborn, it's normal for it not to be able to go back. Okay, but after some time it should be able to go back. In adults also it should be able to go back. Otherwise we have phimosis. But for newborns this is not phimosis. That's another thing to remember. Yeah, so for females, check for clitoromegaly. We said the definition last time. And here we have posterior labial fusion, okay, due to androgens. And we're measuring the anogenital ratio. So you measure basically from the base of the clitoris or phallus towards the anus, and then you measure the distance from anus to the posterior side, okay? And what happens in virilization, the labial fusion, it's like a zip. It goes from posterior to anterior. So it's going to start to be fusing, 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 fusing. So what happens is that B will remain the same, but A will be growing, 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 growing as the fusion happens. So the A becomes bigger and the B is the same. So we said that if it's above half, then we are assuming that there is some androgen effect. Okay, so it should be less than half the ratio. So that's the posterior labial fusion, your anogenital ratio. Yeah, check if there may be some gonads descent. They shouldn't descend in females, but if there is androgens, then there may be some kind of descent into inguinal or labioscrotal folds. Not completely, but a bit of descent. So that could tell us that there was androgen influence. Check for any ambiguity in genitals and check the vaginal opening. Is it pouch or can you see the cervix? This is what we said with the blind dented vagina last time with the 5-alpha reductase deficiency. So remember your testosterone and your dihydrotestosterone, okay? So it's two different structures. And we have the Prader stage to see the virilization scale. So we have number 6, normal male, number 1, normal female, and in between is ambiguous genitalia. So that's your physical exam, okay? Continue with physical exam. Know that in preterm, these are normal, okay? The testes don't descend until 34 weeks, so it's not cryptorchidism. for preterms. You have to wait for them, for the testes to descend. Before that, if you don't feel the testes, that's normal, that's preterm, okay? Yeah, and then C for some pigmentation, remember from physiology and biochem, POMC. So the feedback when you have a lot of ACTH being stimulated or not being negatively feedbacked, it will be created from POMC. So you have the MSH. So that's going to make you pigmentation on the skin. Okay. Oh yes. So to differential diagnosis between a genetic female hypervirilized. Okay, so we have a genetic female who is hypervirilized, and the genetic male which is hypovirilized. So we can do the karyotype, okay? But the problem here is that statistically 90% of hypervirilized females is congenital adrenal hyperplasia. So the diagnosis of hypovirilized males is more difficult. This means that when you have a karyotype female and it's hypervirilized, you start checking for congenital adrenal hyperplasia, you make your diagnosis, that's it. But for male hypovirilization, it's not congenital adrenal hyperplasia. It's some other diseases, and we have so many diseases, so it's difficult. So the boys have it worse, okay? If they ask you in the exam, if you have some virilization problem, would you rather be a genetically female or a genetically male? And you will say genetically female because I can be diagnosed and treated early, okay? So females have it easier than males. Okay, so moving on to imaging. Do your ultrasound, MRI, genitography. It's not done anymore. We use ultrasound. We have very, very good machines now and skills. Yeah, do your karyotype. So sometimes when you do the screening, you need to verify it with karyotype or with some genetic like FISH for SRY region. So always we need to verify our screenings with some karyotype or genetic method. Okay, and then we can also do some like labs if we are suspecting like salt wasting emergency. Just keep in mind that when you have this emergency, your labs will follow the textbook labs that says, you know, you have hyperkalemia, hyponatremia, hypoglycemia. But actually, when they are normal, so they were not in the crisis, they are not in the emergency, their labs will be normal. Okay, so they will be normal, and once they enter the crisis, the labs manifest. So yeah, and we need to repeat them. Okay, repeat the labs every day. If you suspect there is congenital adrenal hyperplasia, because the labs will be normal until the crisis happens. So you repeat the labs, and when the crisis happens, you're gonna see the labs and catch it early and start treating it. Okay. So they may have congenital adrenal hyperplasia with salt wasting crisis subvariant, but the labs are normal until the crisis happens. You understand this topic, this concept, that the labs are normal until the crisis happens?
Um, Actually, I didn't know about this crisis thing. So this means that there is high amount of aldosterone maybe or something that causes this, right?
Well, yes, we're going to talk about it later, specifics. But what happens is that the labs are normal. The hormones and the enzymes are the substrates are a bit changed, but the metabolic panel, so that's your natremia, kalemia, and glucose, they will be normal until the crisis starts to happen. Okay, we're going to talk about this later. Just make sure that if you see normal labs, it's normal now, but maybe in 2-3 hours they're not normal. Okay, so you need to repeat
So
them.
normal doesn't rule out that you don't have it.
No. What can rule out is when you do karyotype or you do some genetics and you see that the genes are normal. And depending on the subvariant, maybe the screening as well. So you find the alternative diagnosis. So to exclude it, you need to have basically the cause for the symptoms. You find the other cause and you can do some karyotype for it, and you see that it's not there, then the genetic, the fish or something, the genetic mutation, then you can move on. Okay.
Okay, thank you.
Hormones, we said, remember, there is some dynamic test. There is like hormones. This is your, you should know this for congenital adrenal hyperplasia. just memorize these steps, okay, basic steps, and make a line. Where does it block? So this is enzymes. So we have one, two, wait, we have, yeah, one, two, three, four enzymes here. And don't learn anything else. Just learn these enzymes that are one, two, three, four enzymes, and then just memorize this substance here and where it is. Okay, because this is what we use for screening, and then the end products just have a general idea how it works. So the way I remember it is like 17A hydroxy progesterone is what we're testing. 21 beta hydroxylase deficiency is what is the cause. And then this is subvariants, but you will not talk about it. Just learn the basic one. This is the classic one. And then we are going to talk about it later. Okay. So just know that we have some labs for hormones, and we also have dynamic tests. For the adrenals, we also have synactin test. So this means synthetic ACTH test. So you just inject the synthetic ACTH and see what happens, okay? Yes, dexamethasone suppression test is also for the adrenal axis. Normal hormones like cortisol, and this is the substrates you can see here. Dihydroepiandrosterone and its sulfate. We said about this already for screening. Yeah, so you have your hormones and your dynamic tests. And then you can maybe do some laparoscopic exploration or gonadal biopsy in case that everything is still unclear. Okay, so you could do that if it's still unclear. And then try to find the sex identity. If it's a late diagnosis and they are coming in as adolescents or adults, you can tell them this is your karyotype, you should be male or you should be female, but they already live their life, so they already have their sex orientation. Maybe they are confused. They don't know why they're the way they are. Of course, now like everything is more open, so maybe they're not confused. They just live their life normally. But yeah, tell them this is your karyotype and tell me what is your psychological orientation, and then we can work on it together and try to make your life easier. Okay, so also psychology. So this question is what I said before. Let's see who was listening. Males versus females. Which one is more dangerous, male or female, and why? Which one is more dangerous?
Male, because yeah, it's more likely. Like I think 90% of females can have CAH, right? Correct?
Yes. So females, 90% is CAH. If you see some ambiguous genitalia female, you say, oh, let's check the CAH. But if it's male, there could be a lot of diseases. We need to make it takes time. Okay, so sometimes it's also so for specifically congenital adrenal hyperplasia, the male will be normal because the disease of the problems of congenital adrenal hyperplasia, the pathophysis is that we have a lot of androgens. So the
Yeah.
male, if he has a lot of androgens, nothing will happen to him, so he will look normal. But if the female is there, she will be virilized. So you can see it. Okay? So male is more dangerous. The female will show the virilization. We catch it early and we treat it. You're gonna see the labia fused, clitoromegaly, or micropenis, depending how big it is. Yeah, but the males, the virilization that the pathophys is doing is actually normal, right? So the diagnosis is missed. So the boy, usually the first manifestation, if it's missed, it's going to be salt wasting crisis. It happens from third to fourth day up to 3 months. And they're going to have low glucose and um, higher potassium and lower sodium. Okay, this is due to lower glucocorticoids and lower mineralocorticoids. This makes the metabolic disbalance. They manifest with vomiting, decreased weight gain, lethargy, dehydration, low blood pressure, and yeah, so it can kill you. So males can be killed, but while the females, we catch it early, we start treating them, they will not enter through this crisis. So you see, it takes some time for the crisis to happen. So from birth, third, fourth day, up to 3 months, and it might look normal, and then boom, you have a crisis. So that's the first manifestation. If it's missed, okay. We have screening. Maybe the doctors see it, and they check it, so maybe it will not be missed. Maybe we have history, family history, so we have like risk factors to check for it. So yeah, like females will mostly be catched. Males, if we don't do our jobs properly, we're missing it, and the first manifestation is salt wasting crisis. Treatment for the ambiguous genitalia and disorders of sex development. It's a multidisciplinary team. We said we need very many different specialties. We have to delay the gender assignment, so we have not to stigmatize the child and also the parents. Emergency, right? Exclude congenital uterine hyperplasia, the salt wasting subvariant. It's very dangerous, so try to exclude that. Just the basic idea, you can read this at home, but the basic idea is that it's easier to raise as females, and the feminization genital surgery is easier, okay? To make the genitals into male, it's more difficult because you have to grow the phallus, you have to find the tissue. So it's better to just cut everything and recreate the female genitals, okay? And they grow as females. Yeah, so if it's virilized female, go with the female way, clitoroplasty, do the things, the genitals, vaginoplasty, and grow them as females. Now, when we have under-virilized male, that's a complex decision, and it depends also when you make a diagnosis and if the patient is part of the conversation. Is it an adult, an adolescent? Can he tell us, I feel like a female, or I feel like a male? Yeah, and so it's easier to make them as females. But if they want to become males, we can do a phallic reconstruction or something. So yeah, like males, it could be both, but females just go with females. That's easier to do. Yeah, genital surgery, we said how to do
Quick
it.
question.
Yeah.
We can't have under-virilized men from congenital adrenal hyperplasia, right?
Yes. So I'm still talking about in general disorders of sex development.
Okay.
So I'm starting first with basics, then we go into details. So I was talking about in general when you have the virilization problem. So all of these things here is for DSDs. So diagnosis of DSDs, how it look like, what are you going to do if you have a DSD, take a history, do your physical exam, see what does the male look like, what does the female look like, use your scale to find the scale, make a ratio to see if there was an influence. Yeah, see the skin. If it's preterm, we cannot use this. Use your imaging to see the internal organs, genitalia, where is the gonads, where are the adrenals. Do the karyotype, is it something going on? Is there some, I don't know, trisomies or some other problems? Do your labs so they don't die? Do your hormones, try to find the cause. Do we have some hypogonadism, primary, secondary? Do the dynamic test, see the axis, adrenal axis, the GnRH axis. And if you are not sure, go inside the belly, look at it, find the gonads, take some biopsy. Is it hermaphrodite virus, ovotestis? Is it like gonadal dysgenesis? Do we need to remove it? Is there a risk for tumors? Yes, this topic was when you do your diagnosis, just remember this. That's why I mentioned congenital adrenal hyperplasia here. The things I was talking about are not for congenital adrenal hyperplasia, are for general DSDs. So to clarify, I just put it here because this is the step where you will do your physical exam and stuff. So I put it here to remember when you do your physical exams that if you're examining a female, always go towards the congenital adrenal hyperplasia pathway, exclude that, and if it's not that, then come and do the rest. While females, do your emergencies, make sure the patient is stabilized, and then start finding what is the cause. Some hypogonadism, some other disorders. Yeah. So for the treatment, we said exclude the causes, and then decide what to do, how to treat them. So it's easier to treat them as females, raised as females, okay? So if it's a female genetically, then just go through that way. There will be less problems, easier to do reconstructions. If it's males, then we have to make a decision, okay? Then we talk about genital surgery. So the kid comes out with some virilization if it's a female. If it's a female, the brother is more than 3, so number 6 is normal male. If it's more than 3, then we can do the surgery. But if it's like mild, like number 1 or 2 or 3, or number 1 or 2, then it's not necessary. Okay, so don't bother with it. Maybe there is maybe some other complications. And the birth certificate can be edited, okay? Just know legally that you can edit it. Yeah, we try to do the surgery before 2 years old. So when the baby grows up, they know that they had it forever. They never remembered living with the genital problem. And also internal surgery. So we said for the gonads and strict gonads, remove them. There's malignancy. Find the cryptorchidism, the tumors or something, and treat the cause. Okay, so we have outside and inside our surgeries. Then we have our hormones. So this is from last time, I think. We have replacement and blockers. Depending on the cause, you can either replace the hormone which is missing or block the hormone which is too big, too much. Just know like the name of the category, maybe one drug name. We don't need to know everything. Just say, I don't know, like spironolactone, it's blocking it's like anti-androgen or something. Yeah, and also remember that the family is affected, okay? Pediatrics is not just your patient, which is the child, it's also the family, the parents, the other family members, sisters, brothers. So the family is also affected. Similar with oncology. Oncology is not just your patient, it's also the rest of the family, okay, affected. In general, all the specialties, I think, is like this. So remember your family as well. Yeah, you can induce puberty. We said this for puberty and yeah, and again, our table here. Okay, so diseases now. This is my notes for congenital adrenal hyperplasia. I can send it to you if you want. These two we're going to do last because it takes some time. So from here, I chose like gonadal dysgenesis, anti-Mullerian hormone, ovotesticular DSD, and 5A reductase to just talk about it very fast to help you understanding. And then we jump up to the two important ones, okay? So gonadal dysgenesis, we did it last time, if you remember. It's a problem of embryogenesis. We said this already. Classification, we said complete, incomplete, or mixed. Mixed is like having like testes or dysgenetic on one side, like streak and Mullerian, so that's your female, and testis and Wolffian, that's your male on each side. Incomplete means partial loss, and complete means complete loss. And we talk about sex reversal. So this is basically the same slide as before. Yeah, so we have a 46XX. Okay, now we have a female who has a gonadal dysgenesis. So what's gonna happen now? This is the complete, or synonym is pure gonadal dysgenesis. What's going to happen here is that we have genetic mutations that make the ovaries not work. So complete means not work, right? If you go here, complete loss of function. So there is no estrogens. No estrogens, they don't have secondary sex characteristics, so that's their puberty. Once they reach puberty, they don't have the estrogens, they don't have the secondary sexual characteristics, but also the gonads, they don't become ovaries, they become streak gonads. And if you remember streak gonads, I don't know if you have it here. Okay, streak gonads means linear and fibrous. So there is no oocytes inside. They are infertile, not sterile because they have a uterus. Okay, they are infertile. Yeah, and the symptoms they have normal female genitalia, internal and external. Why? Because there is no testosterone. Okay, if there is no testosterone, you become a female. This is a different case when it's 46XY, because if they don't have the gonads, they don't have testosterone, so they also become females. So the same disease, if it's 46XX, we can say it's normal female like genitalia, internal and external. But if it's 46XY, it's no longer normal. He will be the same genitalia as 46XX, but he should not have the same genitalia as 46XX. He should have like testes and phallus and all these things. So for him, 46, for her, 46XX, for her, it's normal appearance, okay? So the problems and diagnosis happen in puberty, okay? So she comes with delayed puberty, impaired secondary sexual characteristics, primary amenorrhea. Primary means never had menarche before, so she never had a period in her life. Secondary means that they had menarche before, they had like some cycles and stuff and periods, but now it stopped. So because the gonads are not working, she presents with primary amenorrhea. Okay, so primary amenorrhea, and she has delayed puberty, impaired secondary characteristics, all the problems of gonads not working, while the appearance is female. Okay, so she's female. Diagnosis during puberty, because of the clinics, she comes complaining about these things. Do your genetics, do your karyotype, check your axis, and you're gonna see that it's a hypergonadotrophic hypogonadism. So hypergonadotrophic hypogonadism means that GnRH, LH, FSH is high and estrogens is low. And this makes sense because there's no negative feedback. Estrogens is low because no gonads, and then they cannot negative feedback, and then this one becomes too high. And then you do your ultrasound, you see the streak gonads, okay? So remember we said streak gonads is risk for malignancy. So tumor benign, then turns into malignancy, we need to remove them. give the estrogens and later progesterone. We discussed this on puberty lecture, that you need to make the menstruation happen, and also secondary characteristics. And they are infertile, not sterile, so you can use a donor oocyte and do IVF, assisted reproduction. So that's the female with complete gonadal dysgenesis. When we go to the male now, it's called Sawyer syndrome. Okay, so Sawyer syndrome. I don't know how to read it out loud. I think it's Sawyer. Again, complete. We said no function of the gonad, so complete loss of gonadal function. So what happens to them is that they were supposed to have testes, but they don't have. So the result is female internal and external genitalia, and they assume a female gender identity. So they are similar to them for the genitalia, but they shouldn't be like this. So it's not normal. So not normal female genitalia. So they have female genitalia. When I say not normal, I mean for them, okay? Because for the 46XX, yeah, we expect to have female genitalia, but for 46XY, we don't expect it to happen, to have it, okay? Yeah, so pathophysis is that they have no Sertoli, no AMH, which means the Mullerian structures persist. And then we have no Leydig, so no testosterone, which means the Wolffian regression and female external genitalia. So they look like females. Yeah, so they look like females. The childhood is normal. Why? Because we thought they were girls. We have no idea that their gonads is a dysgenetic testis. We think that, okay, it's just an ovary and it's a woman. And then at puberty, again, they come, like she comes. So it's a patient XY, but we think it's a girl because of the genitalia and how it's grown. Like female gender identity means that the parents buy the female clothes, we give her a female name. So she grows up thinking she's a girl, genetically a girl, and then everything is normal until puberty. Again, primary amenorrhea, it's small uterus, maybe there is a large clitoris, maybe some of testosterone was there, delayed puberty, and then diagnosis is the same and treatment is the same. So we're treating them the same. It's just that she was supposed to have testes and she has these genetic gonads, while the other one was supposed to have ovary and she has these genetic gonads. And they both end up in the same, let's say, phenotype. But the only difference is that this is normal for the 46XX, let's say, but this is abnormal for the 46XY. That's the only difference. And to differentiate the XX, 46XX with 46XY, we just say Sawyer syndrome, just to make sure that, yeah, we're talking about a woman who was XY, a girl, growing up girl, which is XY karyotype. That's the only difference. Everything else is the same. Any question for gonadal genesis?
Just a quick question. The XY, will they be sterile? Can they have any oocytes?
They have a uterus, but it's small. So what we can do is we can do assisted reproduction again. So they don't have AMH, anti-Mullerian hormone, so the Mullerian structures happened. So the Mullerian structures are there. So they have a uterus, they have fallopian tubes, all these Mullerian structures, but there is no ovary. Okay, there's no ovary, there's no oocyte. So we just give them an oocyte and we put it into their uterus.
Mhm.
So it's basically like it's a girl, but the only difference with 46XX is that the genetics are different and the let's say what was destined to happen to this gonad was to become a testis. But both of them have a dysplastic, okay? Both of them have streak gonads.
But this is crazy because it's biologically they're males, but then,
Yes, and they end up the same. Like if you take two patients, like gonadal dysgenesis is pure, the male and female, they would be like the same.
Mm.
So only the genetics is different. Okay.
Thank you.
Then you have the incomplete, we said, and mixed. We talked about it last time. Now 5-alpha reductase deficiency. Remember your enzyme that converts testosterone to dihydrotestosterone. It's more potent, but it's also responsible for the red things. Okay, 3 red things: prostate, scrotum, and phallus. So prostate, phallus, and scrotum is the 3 things that if you don't have dihydrotestosterone, they become like this. That's your blind vaginal pouch. Okay, you think you have a vagina, but when you open it and look inside, there is no cervix, there's no uterus. It's just a pouch. So it's basically like inverted, kind of. Yeah, so we said this, okay. The ratio is important. So what you can do is do the testosterone to DHT ratio, okay? Normally it should be about 10 to 1, but here is 20 to 1. It's like double because testosterone is blocked. It's not getting converted to DHT, so it's accumulating on this side and becomes 20 to 1. This is rare. That's why we don't use it for our exam. Just know what it is. So it's rare. Just know a bit about it. Normal testosterone, okay. And we have low DHT, so the ratio changes. We don't have more testosterone. We have lower DHT. The negative feedback mechanisms will balance everything out. So testosterone will remain a bit the same, but the problem is DHT, okay? Yeah, bilateral test is okay. They have impaired external virilization. This is the red things, phallus, scrotum, prostate. So they look like this. This is our disease here. Internal is male, as anti-mullerian hormone is normal. So anti-mullerian hormone is normal. So yeah, the problem is external. At birth, female abicus genitalia and male internal organs. This is the case here. You see epididymis, testis, vas deferens, seminal vesicles, and then they don't have prostate, they don't have the phallus, they don't have the scrotum. So this is also called pseudovaginal perineoscrotal hypospadias. So it's micropenis, hypospadias, urogenital sinus with pouch vagina. And the problem now it's also during puberty. So we have it at birth, the problem, we can see it here, but also now continuing during puberty, we have a lot of testosterone, which is abnormal. It shouldn't be too much increase the testosterone. And then we have the changes we said about testosterone. And finally, they just lose the gender role. Like they grew up as females as they saw this thing. But then what happened with puberty is that they thought they were females, but now they change into males. So they are confused. So that's another problem. Another problem. Yeah. And infertility. So they cannot make any babies. So that's your 5-alpha reductase deficiency. Diagnosis, newborn, you have a ambiguous genitalia, do some genetics, do some labs, see the axis, the ratio as well, see the axis, how it looks like, and then treatment, depending on gender role. If they think that and they want to be men, then you just substitute the hormones, okay? Give the testosterone, DHT substitution, try to fix it. If they want to be females, then just remove the testes, which removes the testosterone source, so they don't come in puberty and start to have beard. Like they want to be females, and then in puberty they start to have beard and lower voice and muscles. So if they want to be females, just remove it. Yeah, and estrogen, remember that it fuses a growth plate, so be careful with it. Give it only after the growth is finished, okay? They don't have a uterus, so progesterone is not needed. So you see here, there's no uterus, so we don't do the estrogen and then add progesterone and then cyclic fashion to make the menstruation. No, it's not needed here. Just estrogen for the secondary sexual characteristics. Yeah, that's it for 5A reductase deficiency. Any questions for 5A reductase deficiency?
No, it's fine.
Okay. Anti-Mullerian hormone, we said, is also called Mullerian inhibiting substance. Okay, so this is another term, persistent Mullerian duct syndrome. So there can be either, for the pathophyse, a problem of synthesis. So that's your AMH gene defect, which is made by Sertoli cells, or the receptor. That's the AMH receptor 2 gene. So it's either synthesis or receptor. The effects will be the same. This is endocrinology. You need a receptor and a message. If one of them is broken, then you have the same symptoms, okay? So ladies are normal. Ladies are normal. What is affected is Sertoli. So Sertoli, they don't make AMH. So normal testosterone from ladies, male external genitalia, various levels of clitorchidism, and we have some aplasia, epididymis, upper vas deferens, because it's not properly connected to excretory ducts. Yeah, and the testes have higher mobility. So the problem here is that if they are mobile, there is risk for tertiary torsion and then ischemia and degeneration. And you can see this as hematospermia or hematuria. Okay, so make sure you fix these things when you have someone with AMH defect, which is severe. Okay, and then moving on, the problem with AMH now is that the Mullerian female structures persist, right? And we said that the Mullerian structures is fallopian tubes, uterus, and upper one-third of vagina. So this is the problem here. We have a testis which will try to descend, right? But the problem is that on its descent, it's going to take uterus with him and fallopian tubes, and that's the problem. So there is a uterus which is in pelvic location. We have fallopian tubes which during descent they are dragged into inguinal canal. This is called, if it's with uterus, it's called hernia uteri inguinalis. You can see here, it's hernia uteri inguinalis. It pulled the testis when it descended. It pulled the entire, uterus with it. Um, Most common is one descent testis and one cryptorchidis, causing inguinal hernia. So that's like kind of a common. And there is some other variants, like if you have both of them going in on one side, descending on one scrotum. Yeah, so there is different variants. Just know that you have Mullerian structures, but they will descend, and when the testis descends, it's going to take it with it. So that's the problem with AMH defect. So we said 5A reductase is external, like they are not formed, so maybe they assume a female gender role. And then with anti-Mullerian, we have the Mullerian structures, and they are descending through the inguinal canal. So that's like very major problem, like for diagnosis, what you're going to do, what we are going to see. Diagnosis, they have normal genitalia outside and gender at birth, but we are going to have problems with the inguinal hernia, cryptorchidism, like these problems and descent, okay? So they have normal Leydig testosterone, normal genitalia, you're going to see the phallus and scrotum and stuff, but they will have some kind of these hernias. Then you check the hernias and maybe some further investigation or surgery for it, and you discover a uterus and fallopian tubes. So this is like a way to find it when you go to fix cryptorchidism or something and you see uterus and fallopian tubes and stuff. Or you can do the genetics and hormones. So genetics, you're going to find this gene. Hormones, you're going to see the AMH level. Okay. And then treatment, surgery before puberty, fix the cryptorchidism, remove the Mullerian structures, fix the hernias. So just fix whatever is inside here. So that's your AMH defect. Just have a basic idea. You will not talk about this in the exam, just to understand it. Okay. Ovotestis, we talked about it last time. Remember, it's tissues of ovary and testis, both of them. They have different percentage composition. Ovotestis has no spermatogenesis, and then you have different combinations, can be in one side testis, one side ovary, and then depending on how much percentage tissue of testis, then it's also how much it will descend. So it's something similar with the AMH defect, like the testis descends. So here as well, the testis descends, depending on the percentage composition of testis of the ovotestis. We talked about it last time. Pathophysiology, we said, is the SRY translocation from Y to X. So SRY region is going to go to the X chromosome, and the X, instead of making ovary, because of SRY, it's going to try to make testis, and it will end up like kind of ovary, kind of testis. So that's the pathophysiology. And we have the diagnosis, clinical, karyotype, biopsy, and surgery is depending on the gender identity, okay? So we have some differences here between males and females. They both have ambiguous genitalia. It's just like what kind of ambiguous genitalia, and they also, both of them have problems with puberty, okay? But they have different, let's say, symptoms. So XY males and XX females, they have different presentation, but diagnosis treatment is the same. Okay, now let's go to the big questions, the big diseases. Turner syndrome, what is it? Can you try to explain Turner syndrome?
Like karyotype is X0, right? There's missing of a second sex chromosome.
Good. Okay, so it is a DSD of the sex chromosomal category. So this is our category sex chromosome. We have variants, okay? So 45X, you can say XO as well, so X or XO. I think the official is XO. I don't know if it's different between America or Europe. I don't know. So it's 45X. You're right, but there's variants. Okay, so it has many variants and severities. Now, the most common, is the classic complete absence of X chromosome. Okay, but these ones, they will die in utero. So if you did your hygiene and epidemiology, you will know that incidence is based also on diagnosis. And yes, we don't make diagnosis of this dead in utero. So what you're going to see most often in your life are mosaics. So if you see someone with Turner syndrome and they're like living well and getting treated, most probably there will be mosaics, okay? But in the exam, remember that in the exam, what they ask for the classic complete 45XO with the full presentation. So they don't want you to know mosaic, which is the most common thing you're going to see. Mosaic, remember, is one zygote which has a genetic mutation, and then you have the mosaic from one zygote. So they don't want you to say like what you see in the clinics. They want you to know the classical theoretical complete Turner syndrome with all the manifestations. And just a bit of history, Henry Turner was an endocrinologist, discovered Turner syndrome, and he described basically infertility, webbed neck, and cubitus valgus. Okay, so this is the three things that he described first. Pathogenesis, Professor Honzik asks in the exam, which gene is affected? Do you know which gene is affected for Turner syndrome?
SRY gene, I don't know.
No. So if you go back, okay, it's not written here. So I will try to help give you a hint, and maybe it will help you. These patients are short. They have short stature. So which gene? Short stature.
I don't know. You should help me.
Shocks.
Okay.
So short stature, shocks. Okay. So if you know short, they are short, shocks. So it means short stature. This one's shocks. Shocks gene, and it's part of X chromosome. That's why when it's missing, there is a problem. This is the region. We don't know the region, just know SOX gene. Okay. Etiology. So we have complete or partial absence. So either it's absent, okay. Um, it can be mosaicism. That's the second most common mechanism, let's say, but you see them more often because the incidence is based on diagnosis, and some rare one, leonization. This is just theory. Just know absence and mosaicism. That's just these two, okay? Yeah, so mechanism. Number one is complete loss. And these people, they die in utero, so you don't see them. Number two is mosaicism, and yeah, it depends. Like if they are females, half of their or half, like some of their cells will be 45XO. If they're males, half like some of their cells will be 45XO. So this is mosaicism, okay? And this is what you will see most often in your clinics. There's also partial loss, and yeah, it could be XY as well. So it's not just female, it could be XY. Yeah, so you should know the complete one for the exam.
Elias, I'm
Know
a
the
bit
complete.
confused. You said that do all complete Turner syndrome die or some survive?
Most, some survive, yes, but most. Uh, I think I have it here. Yeah, most common cause, but will not see that it's so severe that most fetus die in utero. But it is the only complete monosomy you can survive for long. So they can survive actually. 25% of early miscarriage is believed to be caused by some kind of chromosomal disease like Turner. So the important thing, what I was mentioning, is that mosaicism is like what you will see in your clinics most often. But yes, they do exist, complete and partial absence. And it's the only complete monosomy you can survive for a long time. So maybe they ask you this question. They ask you which monosomy, complete monosomy, you can survive for a long time, and you should know that it's Turner. So I should make that in red because it's important. Yeah, so complete loss is what you should know for your exam. But for your life, know that mosaicism is like what you will see most often based on incidents. So yeah, epidemiology, you see Klinefelter is 1 to 600, but they are 1 to 2,000 born girls in Czech Republic. So Klinefelter should be more common. But what they have in common is that they both have gonadal problems. So they are hypergonadotrophic hypogonadism. Because the gonad is not working, then GnRH, LH, FSH, they go up. Errors happen at random, like I said, non-disjunction is the path of this. So errors happen at random for your second pregnancy to have Turner. Doesn't mean that if your first baby or second baby is Turner, the next one will have higher risk. It's always the same risk, okay? What are the symptoms? So this is what Henry Turner discovered. Can you categorize maybe the symptoms, or do you know some symptoms from third year?
Short stature. Yeah.
Yes, good.
They should be female characteristics, right? Like
Yes, okay. It's a female, okay.
Bicuspid aortic.
Yes. Bicuspid aortic, yes, as well. What is this webbed neck? What is it caused by? Have you heard of Pteridgium coli, maybe? Okay, so how I categorize them, I just went by pathophysis. So, okay, you said these females. You are right, Sriram, females. Basically, I just put some categories here. So, cubitus valgus is skeletal problems, webbed neck, that's your lymphedema problems, and infertility, that's your gonads problems. But I also added more. So we have the SHOX gene, right? So 98% almost always they're short stature. So SHOX gene, short stature, that's your first symptom done. So you remember your pathophysis, you remember your first symptom. So how you treat short stature? Use growth hormone, okay? And acceptable height for females, girls is 160. So you can actually reach it. So short stature, that's your first thing that your SHOX gene will do. But another thing that the SHOX gene will do is actually affect your skeleton, okay? So cubitus valgum, genuvarum, like some other deformities, jaw, high arch palate. So you have skeleton problems, but skeleton is also your ears, right? So external ear canal, ossicles in the middle ear, and this makes conduction hearing loss. So skeleton is not just, let's say, how you look like, but also it's functional. There is functional in the ear, so you have problems in the ear as well. Yes, some more shaped, the stagnant tube is longer, predisposition for that is media. So your skeleton, that's the second category that your SHOX gene will do. Short stature, treated by growth hormone, and then skeletal dysplasia, you have all these deformities based on bone, okay? And this was described already by Turner in 1938. Yeah, this is the labs. The labs would be normal, okay? The growth hormone, it's not a growth hormone deficiency. It's a fibroblast sensitivity or some endocrine problem, okay? And another important thing for labs is that they have insulin resistance. So this predisposes them for diabetes mellitus type 2, hyperlipidemia, hypertension, and they get it since young age, okay? Because it's genetic, it will manifest a bit younger. So you have a bit the labs, the bones, and the short stature. This is what the SHOX gene is going to do. Then the second thing is the lymphogenic gene. Okay, it's also an X chromosome. It's called congenital lymphedema. In the neonates, it's on hands and feet. What's going to happen is that we have the chest problem, the chest. So it's called broad or shield chest with widely spaced nipples because of the edema. Okay, this is pushing it apart. The neck, it's called pterygium coli or webbed neck. It's synonyms. It's basically lateral skin folds between mastoid and acromion. So you're gonna see this. It's like webbed neck. You can see it here. And then on prenatal ultrasound, what you can see is something called cystic hygroma. So the neck will look on ultrasound and we call it cystic hygroma. You can Google that and find it out. But it's going to go away with age, okay? Because it's a lymphedema thing, it can go away with age, the cystic hygroma. Yes, so that's the Turner thing for ultrasound for your gynecology. So remember your chest, your neck. Then we have some other things. So you should know your craniofacial dysmorphia. Okay, know how the faces look like. They have some low posterior hairline, so the hairline goes back, lower, and know your faces how it looks like. Low set earlobes, triangular or heart shaped. So it's a synonym. You can see here. It's the face. Flat nasal bridge. So this is flat and epicanthal folds. So you have the epicanthus there. And then, okay, some more things. And then a horseshoe kidney. So we also have internal, okay? So internal organs as well. Horseshoe kidney. Like for Turner, you can speak for hours. That's why I chose it, because it has so many symptoms. And if you go there with, okay, I chose congenital adrenal hyperplasia and Turner, you can use this for many diseases, and there's a lot of information on it. Also, the next one is cardiovascular. You said bicuspid aortic valve. Yes, that was correct, with risk for aortic stenosis. It can also be for coarctation. So if they ask you in the coarctation some causes, you can say Turner. Like you can talk about it Turner a bit like there as well. Yeah, predisposes to congestive heart failure. So what we need to do is regular cardio checkup for the aortic rotation, stenosis, bicuspid valve. So check your heart as well, okay? And when they're adults, the professor said it's like a connective tissue-like disorder. So they had a patient who had like this dilation of the aortic root with the risk for rupture, especially with hypertension, because we said before that this can make hypertension in these patients. So this patient was female, and she tried to do birth with IVF, and she died by aortic rupture on delivery, because delivery is very stressful. So remember your cardio, okay? Then some autoimmune, okay, and some not neurocognitive, okay? Compared to Klinefelter, they have some problems. Klinefelter has neurocognitive problems, but Turner doesn't have. So that's another difference. So how I classify it is my SHOX gene, which is my skeleton and my short stature. Then I have my lipogenic gene. That's all the edema things that you can describe the features. And then I have my cardio. That's the three things I'm using to describe the symptoms. Like try to make it more logical. I think if I go Pathophy's way, it's gonna be easier, unless you have some mnemonics or something. And the final one, if you go back, he said about skeleton, he said about lymphedema, and he said about gonads. So going now to the last one, gonads, very important. Gonadal dysgenesis, we spoke about it already. Strict gonads, which means linear, and they're fibrous, they don't have germ cells. Yeah, so it's strict gonads, we showed it last time, and they are high risk for malignancy, right? So we need to remove them. What is the pathophysis is that if you have unpaired sex chromosomes, they cannot enter meiosis. So if you try to treat it with estrogen, it will not help because the genetics, they cannot do meiosis. So that's it. It's untreatable. You need an oocyte donor for it. And now some small exercise. So it's hypergonadotrophic hypogonadism. Is GnRH high or low?
High.
High. FSH high or low with LH?
High.
High. Ovarian sex hormones?
Low. Yeah.
Low. And secondary sexual characteristics high or low?
Low. Yeah.
Exactly. So yeah, so that's hypergonadotrophic hypogonadism. Don't confuse yourselves. Yeah, and the infantile hypoplastic uterus looks like this. So it's small. It's small. Need to give some hormones maybe to make bigger. Delayed puberty. That's why we're talking about it also in puberty question. Primary amenorrhea. We talk about it. That it means they never had menarche. Infertility. Why? Because they have donor oocyte. So it's not sterility. And there's only like 2% that have normal fertility, but don't mention it. Go with the classic, say infertility, and use oocyte, okay? Versus Klinefelter, Klinefelter is sterile, okay? Just know the difference. Okay, diagnosis. How many of the patients are diagnosed in newborn age, childhood age, and adolescent age? How many percent? How would you split it? The 100%. How many percent newborn?
Maybe more in adolescent.
Okay, okay. Why?
Um, because they don't grow tall, right? So you will notice that, I guess.
Yeah, okay, you're good. So we have different severities. Why? Because we said if we go back to classification, where's the classification? Yeah, we have Turner and variants. Okay, so if you take Turner and variants, how you can split up is 1/3, 1/3, 1/3. So it's equally. So in newborn, you're gonna get the 1/3 that have the severe one. They have typical dysmorphia, right? You're gonna see all these symptoms. You're gonna catch them in newborn. In childhood, you will not catch the severe ones. You will only catch the non-severe forms due to short stature. Yes. And then in adolescence, the delayed puberty. So the less severe they are, their genetics, the different presenting symptom they will have. So the severe ones, this is what they want to hear. Okay, newborn. This is what you will see in the severe one, newborn. And then if you are mosaic or something, you have childhood and adolescence. Okay, so the less severe, the more mosaic you are, more mild you are, you will be diagnosed in childhood or adolescence. But the severe one they want to hear is newborn. Okay, so if they ask you in the exam, when do you diagnose Turner, you can say newborn. And if they say no, not exactly, you can say yes. If it's not severe, you can be childhood or adolescence, depending on what is the presenting complaint. Okay, so go with newborn because we're talking about the more severe one. Okay, prenatal test, do your ultrasound, see your cystic hygroma coli, do some testing, find the karyotype, okay, so we can see it and diagnose it. Just know that the PCR, if they ask you, can we use PCR? You say no, we still need karyotype, okay, it's the gold standard. Then postnatal, again, karyotype. Do your ultrasound, see the ovaries, see your coarctation of the aorta, your horseshoe kidney, so see the organs inside, and also do your thyroid, okay? They have thyroid problems. We said before that it's autoimmune. Check your axis as well and exclude secondary causes. So prenatal, you can do it by karyotype. Postnatal, again, karyotype. This is just things you can do, but karyotype is the gold standard. Treatment, short stature, we said growth hormone, okay. You can use some estrogens, but they have to be low dose because remember in puberty lecture, we said that there is growth plate fusion. Yeah, so there is some, if they ask you for growth hormone, like what is the negative of growth hormone, why we don't give everyone whole growth hormone, is that there is risk for intestinal adenoma. This is very low, but there's still some risk, like growth hormone dependent cancers, okay. Yeah, this is like ancient Czech thing. They just break the bone and make it longer. But now we have growth hormone. So since 1991, we just go with the hormones, less invasive. And if it doesn't work, then you can do the orthopedic surgery. What is important is they will ask you what are the other indications for growth hormone. So it's like growth hormone deficiency. That's the most logical answer. Turner. So we did it now. And then you can also have chronic renal insufficiency with growth failure. So you try to fix the growth hormone problem in chronic renal insufficiency. Prader-Willi, intrauterine growth restriction, or small for gestational age with postnatal growth failure. So not always, only the ones that they fail to grow. And then also the latest one is rasopathy. So an example is Noonan syndrome. So just read 5 sentences on Noonan syndrome because the endocrinologists, professors like it. They don't discuss it so much like Honzig and Zeman, but there is one endocrinologist who asks about it, but she's not the main examiner. Yeah, and for the ovarian dysfunction, we have our goals here, what we need to achieve, and how to do it. Okay, so it's a female, so we need to do the cycle with the uterus. It's exactly what we said before in puberty, that like induction of puberty, that we said you start with estrogens, and you add progesterone, and then you stop, and then you make a cycle. So this is the cycle of how to do it. Okay, fertility, we said donor oocyte IVF, and yeah, before doing anything with estrogens, because we said they will fuse the growth plates, just do a bone age. Okay, take your baseline, take your bone age, and if you follow it up and you see that the bone age is advanced, stop your estrogens. We don't want premature fusion of plates. So okay, we can use estrogens to make them look like fix a bit the secondary characteristics and everything, but the goals is also the height, the bone density. So it's not just secondary characteristics and menstruation. So check your bone age as well. Okay, we want them to be high. We said in the puberty lecture that endocrinologists, we care a lot about total height in the end, terminal height. We care a lot about that, not just the sexual characteristics. And the prognosis, very good prognosis, give the growth hormone, they can reach the height they want. We can give them hormones for puberty, menstruation, and we can do IVF. So that's very good prognosis for Turner. And then we will move on to Klinefelter and then congenital adrenal platelets. So any questions on Turner?
No, it's good.
Okay, moving on to Klinefelter. What is Klinefelter?
XXXY, like 2X and Y.
Okay, but again, remember, we said that the classification is Klinefelter and variance, okay? So Klinefelter and variance, it can be 48, 49, okay? 47 is 90%, so that's the most common, okay? So it's part of the sex chromosome DSD classification, okay? It's 47XXY 90% of the time, plus variance, that's 10%, okay? It's an XXX chromosome in man. Turner is a lacking X chromosome in woman, right? So he will grow up to be a man. So his gender identity is man, while gender identity of Turner is woman. The more chromosomes for the variants, the more chromosomes, the more pronounced manifestation it is. Mosaics are less severe. Okay, they will also have some polymorphism. Good. Most due to non-destruction in meiosis, that's the etiology, and there is higher risk in higher maternal age. So now for your gynecology exam, from which maternal age is the pregnancy automatically considered high risk? So which maternal age? And also, what does it mean high risk pregnancy? They asked me in the exam. My exam, they asked me about high risk pregnancy.
Is it 30?
Okay, you are a bit close. It's 35. And what does it mean high risk pregnancy?
More likely to have disorders of the karyotype or something like this, or
Okay,
stillbirth.
yes. So, okay, but it could be also other diseases. Like, for example, diabetes women are also high risk, but they don't have any genetic problem. It's just they're diabetics. Uh, what do we do with high risk pregnancy women? What do we do with them? Why do we care to label them high risk?
So they get more care during pregnancy, like we check the hypertension and all these other things.
Okay, so additional test, let's say no, but we do the test the same, but what is the additional thing we do? Okay, I'll help you. It's more visits, okay? So there is the standard, yeah, there is the standard schedule. We try to balance the money from the insurance and our time we spend on them to the benefit. Like we're not gonna check them every 3 hours or every day or every week, right? So you try to do like some trimester screenings and try to space them apart. So to make it as economically and time efficient as possible without endangering the life of the mother and the fetus. But when this mother is above 35 years old, she's high risk, so I will see her more often, okay? And probably I will be more willing to do some more exams. So I'm spending more time on her, more money on her, and I can justify it because of the, like I'm saying, I cannot neglect her. She's a high risk pregnancy, okay? So she doesn't follow the standard schedule, which is the most time efficient and money efficient. We follow a more intensive schedule. Okay, yeah, so that's a numerical aberration, from genetics. Epidemiology is more common at Turner, 1 to 600. It's the most common cause of hypergonadotrophic hypogonadism. This is the exercise we did before, like with GnRH. Risk factors, more than 35, okay? It's a high-risk pregnancy, and we see them more often. We may do some more tests, but you should do the same test to everyone. You should not neglect. More tests when indicated, let's say. So that's a scheduling problem, scheduling change if you're high risk. Symptoms, any symptoms of Klinefelter? So it's a man. Any symptoms?
Hi, Bastian.
Say once more.
Yeah, hi. They probably have gynecomastia also.
Yes, good. That's correct. Yeah. So we have body things, gynecomastia, as you said, they are very tall, long limbs, but they have short torso. So there is some disproportion. So you can recognize it by the disproportionality. This is due to the growth plate fusion. So they had the delayed growth plate fusion. So that's why they grow so tall. Okay, so they have the long limbs. Yeah, gynecomastia, that's your what you said, less muscle mass and weaker bones. This is the estrogens and playing the role. And less facial hair, okay? But the adrenarche is normal, okay? So remember that adrenarche is not affecting the gonadarche. We said this in the lecture of puberty, that one axis does not affect the other axis. So pubic and axillary hair will be normal. So this will create some confusion. They will think that yes, I'm doing puberty normally, I'm getting hair on my axilla, on my pubis, but this is not actually a secondary sex characteristic, let's say. It's more like adrenal characteristic. So the woman could have it as well. Yeah, so facial hair, you should focus on that. Ask your patients, do you have facial hair? Some other thing of secondary sexual characteristics like muscle mass or yeah, like try to check the secondary sexual characteristics. They have also some cognitive problems and energy problems, okay? And for hypogonadism, you know it's the same as other diseases, so hypogonadism. And then, yeah, moving on. How do you make the diagnosis and when do you make the diagnosis for Klinefelter?
You make it with karyotype, right? You have to do
Karyotype, that's a gold standard. Yes, good. Karyotype is the gold standard. You should always do your karyotype if you have some clinical suspicion. And then do your labs, of course, check your axis. What happened here is that most patients aren't diagnosed, okay, because they look normal before puberty. They look similar to other boys, so no one checks them. Let's say the karyotype, or try to find what is the cause. But during puberty, the symptoms are more prominent. They start to manifest, as you said, gynecomastia. They are very tall because this is where they are growing, and the growth plate fusion does not happen; it's delayed. So this is where you're gonna have um, your diagnosis. Okay, so depending on severity, severe phenotypes, you can see it on neonate or pre-puberty due to the symptoms we said, and also intellectual problems. If it's moderate, you're gonna see it in puberty. You have the delayed puberty, gynecomastia. You have some secondary sexual characteristics problems, and the legs grow out of proportion to the arm length, so they are growing very tall. And if it's less severe, maybe they come with infertility questions, but they're actually sterile. They will complain for infertility, but you will find out they're sterile. Azoospermia, gynecomastia, osteoporosis. So the less severe, the further away in the life you will diagnose it. Yeah, and treatment is lifelong testosterone replacements. If they are adults in work, they have a working schedule, so you can give them some topical gel they put on their genitals and their thighs, inner thighs, or you can use some systemic, so subcutaneous testosterone. Yeah, and for sterility, they are sterile. They cannot make their own children. They just have to adopt or like use some sperm donor and then fix the other things, okay, with some like symptomatic. The question they will ask in the exam is, uh, a woman came and she's pregnant and her husband has Klinefelter, and he insists that the father is like he's the father of the child. Is this possible or not?
It's not possible, right?
It's not possible yet because he's sterile. So it means the baby is not his. I don't know. It's kind of like let's say like a joke or something. But yeah, it's to show you that if you see a pregnant woman with Klinefelter, it's not his. Yeah, so this is from Up to Date. It shows you like the manifestation at each age, uh, and then also the treatment for each age. So I just had it here like to have a general idea of that it's growing like this. And the more blue, it means it's where it's going to be diagnosed, the most common. So the most common is, as you said, like during let's say adolescence or puberty. That's the most common because that's where you see the height, and then before that, if it's severe, also a neonate, but before that, we think that they are normal, so we don't diagnose it. We diagnose it in maybe adults with problem, adolescents with problem, in neonate if it's severe, sometimes prenatal, okay? And this is the treatment for each stage. That's our Klinefelter. And finally, the last question, congenital adrenal hyperplasia, last disease. So what is congenital adrenal hyperplasia?
Higher production of adrenal hormones in children.
Okay, is it one disease?
Mm. What do you mean? Like, are there variants or like that?
Is it one entity, let's say?
I think there are multiple deficiencies of hormone.
Exactly.
can-
So it's yes, yes, yes. So it's they are autosomal recessive defects. So it's many groups. Okay, depending on which enzyme is affected, it's still congenital adrenal hyperplasia, but it depends on which enzyme is affected. So it's a group of, let's say, enzyme deficiencies of the adrenals, something like this. And this makes less cortisol, less negative feedback, more ACTH, and then finally the hyperplasia happens. Okay, so congenital adrenal hyperplasia is due to having the loss of negative feedback, and this will create the adrenal hyperplasia. So it's a group, it's many defects. Just choose one. Each enzyme has their own entity. So what is important for us is this enzyme over here. So this is enzyme that is most commonly affected, and then like this is the blockage that happens. So they go down. We don't produce them anymore. They go down, and this one is what we use for screening. It goes up. Okay, this is for your adrenal here. Remember sulfate. Okay, just for congenital hyperplasia, no 21 beta hydroxylase deficiency, and that we use 17A hydroxyprogesterone for screening. And there is a difference between class 6 and both of them, or salt wasting crisis. So let's just classify it now. How to classify it? There is many like entities, let's say. The most common is 21 beta hydroxylase deficiency, that's 90%. The second most common is 11 beta hydroxylase deficiency, and the third is like 3B, 3 beta hydroxylase deficiency. And this is what they discuss in USMLE as well, but it's very rare, so we don't care for it. So in your exam, what you will focus on is this one here. So classic, salt wasting, and simple virilizing. They will grill you on this one. That's why it's red. It's what you need to know very, very well. But because it's one enzyme and we do screening for it, we need to be able to differentiate between non-classic or late onset, this is synonyms, and the simple virilizing. So they want you to know salt wasting classic, but it should also be differentiated from non-classic and simple virilizing. So that's why you should know this very well. And then for these two, just know the differences, just the basics. So the classic, know it very well to differentiate these two. So I color coded it a bit. So let's go by colors. I will have here like the drawing so you don't forget where we are. So this is now the blue one. So number one, 90% of the time, it's the most common, 21 beta hydroxylase deficiency. In Czech Republic epidemiology, 1 to 12,000. Okay, so it's fairly common. What happens is that you get more androgens and 17 hydroxyprogesterone. This is the green one here. So this goes up, okay, and also progesterone as well. This is this one over here, and then androgens. They are shunting down the androgens pathway. This is the pathophyse. Reminder that external genitalia virilization process, we just need androgens, so testosterone and dihydrotestosterone. If you have very high levels of these two, you get virilization of the genitals. So this is what happens here. Like it goes down the pathway, you have testosterone, and then you have 5A reductase, so dihydrotestosterone, and you have external genitalia virilization. Hypertrophy and enlarged adrenals, we said about it already. Okay. Now moving on down one step, classic, that's our yellow page. So on chromosome 6, you see it in infants and children. They have more androgen exposure in utero. So depending on the gender, we have different, let's say, manifestations. So it's what we said before. If you are male, you will look normal because we expect you to have virilized genitalia, to have a phallus and scrotum. So the doctor thinks it's normal. So they will look at you at birth. You're going to have normal external genitalia at birth. They miss the diagnosis, and this put you at risk for salt wasting crisis. So you're going to come back with a under crisis. So the first manifestation is salt wasting crisis, happens from around like 3-4 days until 3 months. Okay, but usually it's 3-4 days until 14 days. So that's like first week, second week. That's where they will manifest, but it can take up to 3 months to manifest this. So don't miss it. If you see some kind of problem in a male with ambiguous genitalia, no, in female with ambiguous genitalia, you check for congenital hyperplasia, but for males, you will not realize it. So the males, they will be missed. So what we need to do is screening. That's why we have the screening, and they will ask you a lot about screening. Okay. Yeah, this is how the male will look like with a large phallus and a dark scrotum, but you might think this is normal. So if you see these two, try to see, is it congenital hyperplasia? Can I do some tests? But otherwise, if the screening is negative, then they will be missed. Yeah, so the screening should be 100% getting them. So if they do the screening, you shouldn't miss them unless something went bad. For females, yeah, it's virilized external genitalia. So what happens, you see this female with ambiguous genitalia, large clitoris, urogenital sinus, labial fold fusion, and then you catch a diagnosis and you start treating it. So if you see a female with ambiguous genitalia, you will find a diagnosis and start treating it, but the male will not be caught. You will miss a diagnosis because you think it's normal, but actually it's not normal. Yeah, internal genitalia is normal, okay? The internal genitalia is not affected because high testosterone, high dihydrotestosterone is only important for external genitalia virilization. So this female will have external genitalia ambiguous, but internal is normal female. That's our female patient. We see the external genitalia, we catch the diagnosis, we treat it. While the male, if we don't do the screening, we miss a diagnosis, he's risk for salt crisis. So that's the most important point here. Any questions on this? Did I confuse you?
No, it's fine. But just with screening, when we're screening, it's the 17 something, right?
Yeah, exactly. So I'm gonna show it after, but you should know the screening very well. You have one question just on screening, and they always like to ask, how many percent is, no, basically, first question, what is this test checking? Is it immunoassay? Is it ELISA? Is it, I don't know, some hormone level? What is it? And how do you test it? Then the second one is, what is the catching rate? Like, what does it catch? How many percent of the patient does this catch? Is it like
Like
very
the
specific,
specificity,
sensitive? What?
like specificity, right?
Yeah, and they will not ask you for sensitivity, specificity, I think. They will ask you how many percent of the patients are caught. That this is what the terminology that they like to use.
Okay.
And then what the next question is, what is false, maybe positive or false negative, or what is missed? So what they like to ask is, how do you do the test? What is caught and what is missed? And this goes for your thyroid disease, for your congenital adrenal hyperplasia disease, for your basically your screenings, pancreatic cystic fibrosis. They want you to know what is missed, because as a doctor, when a patient comes with a screening which is negative, you should suspect, oh my God, this guy was missed due to this reason. So for I will talk only for congenital adrenal hyperplasia this time for screening. Okay. This is the red one, going to down to red. Why I make it red? Because you should know everything, like everything on this slide. It's made up of 75% of the classic. So the classic, 75% of them is salt wasting subtype. The activity of the enzyme is 0%. Okay, this is the difference between simple virilizing and salt wasting and non-classic. So these three ones, they are the same enzyme, and what differs is the activity, the percentage activity. So this is 0%, this is 1%, and this is 20 to 50% activity. So this is the most severe because it's 0%. It doesn't work at all. Okay, nothing. This causes less aldosterone and cortisol, and we set the negative feedback. That's why there is hyperplasia. We spoke about it. Screening finds 100%. Okay, so salt wasting is caught 100%. If you do your screenings and you do it properly, you should see your salt wasting subtype. Okay, you should screen and catch it. So if, like the scenario we spoke before about the male which is missed, is when usually something went wrong with the screening. But if everything goes well with the screening, both genders are caught by the screening, 100%. Okay, so salt wasting is 100%. Otherwise, females are diagnosed at birth, and then males, if not at birth, then you have salt wasting crisis. Okay, what does it mean, salt wasting crisis? It happens between 4 and 14 days, maybe up to 3 months after birth, due to low cortisol and aldosterone. So what happens is you urinate sodium, so that's why it's called salt wasting. Symptoms, metabolic failure, that's your low NA, high K, and low glucose. These make you seizure and confusions, right? Hypoglycemia, it's like a diabetic, low hypoglycemia patient. So seizures, confusions, failure to thrive, and lethargy and vomiting. So this is your dehydration and hypotension as well. Remember that the child is now 4 to 14 days after birth, right? Maybe 3 months. So he cannot talk. He cannot tell you have abdominal pain. So you cannot say the patient has abdominal pain because he cannot tell you that. So what you can say is that they are crying a lot, they are not soothing, they cannot sleep, they are vomiting all the time. So be careful when you describe the symptoms of salt wasting crisis in its very young age. So don't say abdominal pain. Say vomiting, lethargic, like they're not moving around. Maybe they're aggravated sometimes, but then dehydration will happen, hypotension, so they will be exhausted. So they are exhausted, this child, these babies, and then finally sudden death, they die. So that's why it's an emergency, we need to treat it. So important for treatment is that we need to give them like fix these things, fix the metabolic failure, but also fix the dehydration and also fix the cause. So it's a bit like three-way how to do it. So you give your dextrose, that's glucose and fluids, right? So dextrose is glucose and fluids, and give some saline, that's sodium and fluids. So you're giving them glucose, giving them sodium. So we fix these two. Now potassium. So potassium will resolve after everything else is resolved. So don't try to do anything for kalemia. Hyperkalemia, if it's not solved, you can use insulin and glucose or some other treatment methods, but we prefer insulin and glucose since it's the most like physiological, okay? Now, the other thing is that we need to give also cortisol, because cortisol is the hormone needed to survive. If you don't have cortisol, you die. So we give them IV hydrocortisone, okay? So this is our salt wasting crisis. Something here, no? Okay, any questions on salt wasting crisis?
Just to clear up, do you see salt wasting crisis only in males, or you could see it in females too, right?
It could happen in both, but it takes 4 to 14 days, right? So you saw the girl who was born and she had ambiguous genitalia. Are you going to send her home or keep her in the hospital?
Yeah, true. Yeah.
Exactly.
No,
So
you can't send her home. You have to.
yes, you can just keep her in the hospital, do additional tests. You're gonna find congenital adrenal hyperplasia, and you're gonna start treating it with mineral corticoids and glucocorticoids. We need to substitute both because less aldosterone and less cortisol. So we need to substitute both. So you go causal on the girls. On the girls, you go causal, but in males, you send them home because you don't catch the disease. Maybe they didn't do screening or something went bad with the screening. They should be like screening finds 100%, so it should be found. If it's not found, then something went wrong. You see the baby, you don't understand it's a salt wasting subtype. You send it home. It presents after 1 to 2 weeks with this salt wasting crisis. So then this is a treatment for the salt wasting crisis, okay? This is a treatment for the crisis, not for the disease. For the disease, we're gonna give glucocorticoids and mineral corticoids. Okay, so I just need to do I just want to finish simple virilizing, then jump back to classic. Simple virilizing, that's 25% of the classic. So this is less common. It's 1% activity. So we said 0% salt wasting, 1% simple virilizing, and 20 to 50% non-classic. Okay, so this is now where the green space, 1% activity, it has low cortisol, but it's enough for basic life. So there is no salt wasting crisis. So the difference between salt wasting and simple virilizing is that this 1% is enough so they don't have the crisis. You only have the crisis if you have 0% activity. That's your salt wasting subtype. The problem here now, screening finds 66%. So that's 2/3. So 1/3 are missed. So remember that salt wasting is caught 100%. The simple virilizing classic is caught only 66% of the time. It's the same enzyme, so it's the same test we're doing. And then we have to see like how many percent are caught. So this is 100%, this is 66%. 1/3 are missed. This is important for your screening and also for your exam, okay? Remember this. The ones that are missed, they are going home and they will present as an infant who had failure to thrive, hypotension, dehydration, etc. So yeah, it will have it will not have a crisis, but it will have like kind of like the symptoms, but not so severe. Same thing, there is more androgens, the female is virilized, and then also some precox puberty, pseudo-puberty. The male also pseudo-puberty precox, but this is isosexualis. The female is hetero because we are talking about androgens. And this is pseudo-pubertas, so remember, pseudo means immature gonads. That's why pseudo-puberty. Pubic and axillary hair at 2 to 5 years old. This is because the androgens are adrenals. Okay, so we have adrenal androgens, not gonadal androgens. So they will not get secondary sexual characteristics. They will get the adrenal androgens, and then finally they will get a bit of like sex hormones, and they will have pseudo-puberty, immature gonads, and they will start to get secondary sexual characteristics. Yeah, both genders, they have high growth and advanced bone age, and finally they have lower terminal height. We need to fix this one. endocrinologists care a lot about this. We need to fix the terminal height. So that's our simple virilizing. 1% screening finds 66%. Just know this one. Okay. And then why is it called simple virilizing? We have virilization and pseudopubertas precox. That's it. You don't need to know any more than this. You should spend more time on the salt wasting. What you need from this is how much percentage, how many percent, and like epidemiology, and what is the screening. And this you can figure it out on the spot. What happens, like it's called presenting complaint, like presenting symptom for the ones that are missed. You say they come in as infants, failure to thrive, hypotension, dehydration, and then you just name some symptoms. So this is important for this simple virilizing. That's it. Yeah, going back to the entire enzyme diagnosis, some low cortisol. If it's a salt wasting subtype, we also have low aldosterone. High 17A hydroxyprogesterone and testosterone and androstenedione in both subtypes. So for the classic, both subtypes have this. During the crisis only, you have hypo-NA, hyper-K, and hypoglucose. If it's out of crisis, this will be normal, right? So we said that you will not find them if they're out of crisis. So what you can do is the synactin test. This is synthetic ACTH test. It's like a stimulating dynamic test. It's a dynamic test to find what will happen is that you're going to have a lot of 17A OH progesterone. So it will go up a lot if you give synactin because you're stimulating the adrenals, but the enzyme is blocked. So you're going to get very high 17A hydroxyl progesterone. Okay, karyotype, golden standard, and screening. Remember your screening, 100% of salt wasting subtype, 60% of simple virilizing subtype, and false negative could be, if they ask you like what is false negative, is when the mother was taking glucocorticoids during pregnancy. This means that there was negative feedback, so there was less ACTH and there was less 17OH progesterone, which is what we use in screening. So this is what we checked, and it was normal, but it was falsely normal because the mother was taking glucocorticoids during pregnancy. So that's the diagnosis. The treatment in the acute, in crisis, we said rehydration, fix your glucose, your electrolytes, give your cortisol. And long term, we need both glucocorticoids and mineralocorticoids. So both of them, give both of them. And then as endocrinologists, we care for normal growth. We check their bone age, maybe reduce glucocorticoid dosage if it's advanced because glucocorticoids, they will fuse the bone age, the growth plates, and they will be shorter. And then for the puberty, fertility, sex life, yeah, we can do some reconstruction and genetic counseling. So if they can like have a baby, they can terminate it or maybe start dexamethasone prenatal to their fetus if it's female to prevent virilization. Yeah, okay. Follow up, do you know this one, plasma renin activity? So plasma renin activity is what we use to check our dosage. Of course, we check the level of 17A hydroxyprogesterone, but also plasma renin activity. What does it mean is when you have more aldosterone, this is the drug we give, there is more sodium reabsorbed and more blood pressure. So renin doesn't need to be activated. So there is less renin. So this is less PRA. So the higher the dosage, the less the plasma renin activity. So if we have high plasma renin activity, it means we're under treating it and we need to increase the dosage. But if it's low plasma renin activity, it means we're over treating it and we need to decrease the dosage. So yeah, know this concept here of plasma renin activity. And then check everything else as well. So that's how you follow up these patients. And the non-classic, that's the late onset. We said 20 to 50% of activity, same enzyme. It's milder, presents in adolescence. That's why it's called late onset, because it's adolescence. There are higher levels of androgens, but not virilizing levels. Okay, so there's also mild activity of mild levels of 17 hydroxyprogesterone. I think this should be alpha here. I'm not sure. Okay, and yeah, this is the symptoms. Just know a bit basics about this because it's like what is the difference? I think the most important thing is that this is the activity and it's milder. Okay. And we said here, you confirm by synactin test, they're going to have super high 17-hydroxyprogesterone when you do the synactin. Males need no treatment, females depends if they want to be pregnant or not. Yeah. Okay, and moving on now to the second enzyme, that's 11-beta hydroxylase. It's only 5% of the like congenital hyperplasia, so it takes only 5%. And it's some different enzymes, it's the ones over here. So it's this yellow enzyme over here. So it's blocked here, and these two ones are getting high. So that's 11-deoxycortisone. It's glucocorticoid, but has a lot of mineralocorticoid activity. And then we also have more 11-deoxycorticosterone. That's a mineralocorticoid. And we also have more going up our sulfate, right? So dihydroepiandrosterone and dihydroepiandrosterone sulfate and androgens going down. Yeah, these are the symptoms and the treatment. Okay, remember that it's contraindicated spironolactone in these patients, but I think that's too much. If you know your salt wasting, classic, simple virilizing, general for this enzyme, and the screenings, I think that's enough. Just know basics for this. I think that's the only thing I learned, I think, for this. Yeah. So any questions?
No, I think it was all okay. Yeah.
Okay, if you have any questions, you can always like contact me, text me. Yeah, and if you go on the website or leave a feedback, then I'll send you a certificate. Okay. And I will try to upload my notes again and send you my handwritten notes. You can read it much faster on your own. Just send me which topics you want because there's too many questions.
Okay.
Yeah, and all the recordings are on YouTube, so you can just watch it there. Maybe put it double speed or something, and you can save time.